Thank you, Madam and Dr. Prasan, for choosing me for this topic. I like to say before starting my topic is that there may be many of the slides you have seen in last yesterday as well as today, but I have to keep it because of the presentation itself in on a PH. And I kept my presentation very basic because it is multifactorial. I cannot cover full. I have covered it broadly because I cannot cover individual lesion wise also. So presenting perioperative management of pulmonary hypertension and sorry. As this diagram shows that whenever there is a RV afterload increases, obviously there will be a multifactorial left ventricular preload as well as cardiac output reduces, and that is why this topic is very important for the perioperative physician also. And we have come across many patients with PAH with a different lesion preoperatively. This is a case of mixed type TAPVC, POD third, the PA pressure has come down. Initially it was on a higher side. This is a case of status was VST closer, 3 months old, down child. POD second also the PA pressure remained on a higher side because of associated problems. This is a case where PVRI was initially on 7 high and Down syndrome. We decided in the multi-team meeting that we are going to do a fenestrated VST closer. The PA pressure was on a higher half of the systemic. This is a case of complete avicanal aviceptal defect, 8 months old, associated with another comorbidity Down syndrome. This patient also having a high PA pressure on POD3. And this is a case like severe PH come with pregnancy. We forced to kind of, in spite of discouraging the pregnancy, they come to us and then we have given perioperative management of the such kind of patients. So it is broad spectrum, and I'm going to cover only few of the topic. What is PH? I have to do this because of maintaining the flow of this presentation. How to predict preoperatively, which are the subset will give trouble postoperatively as well as intraoperatively, and what are the broadly treatment option available. So I have to keep this slide, though the audience very well aware about this, that mean PA pressure more than 25 is called as severe PH, and it has to be at rest, and it is beyond the infancy. These are the two things associated with this definition. So this another definition is published in perioperative anesthesia management, and this author has further divided into pre-capillary and post-capillary, where the pre-capillary, the PCWP is less than 15 associated with high mean PA pressure, and the post-capillary it will be passive and as well as reactive, where the PCWP is more than 15, but TPG one side is in a passive is less than 12 and the other side is in more than 12. So this is the published data on updated clinical classification of PH, where I think there are two or three updates has happened in this. One is they added PPHN in newborn, as well as the another group they ordered is congenital acquired left heart inflow and outflow tract obstruction, as well as cardiomyopathy. Apart from that, there are few of the other additions. I am not going to go into the detail. The other important thing for me is PH, which is congenital heart disease, and they have divided into the 4 groups. One is isomerized group. To start with, there was a last shunt and then end up in reversal of shunt flow because of continuous damage to the pulmonary vascular beds. So these are the patients. I don't think that these are the patients come to the operation theater, but recently few of the case series which in our unit we have done in Potsons. So these are the also patients we come across inside the OT as well as post-operatively. Coming to the left to right shunt, where the correctable lesion and non-correctable lesion, depending on the PVR preoperatively or depending on the age and other factors, it goes into those group. Coming to the PAH associated with coincident congenital heart disease, where the very small defect, but the PVR or pulmonary vascular resistance is coincidentally very high, which will not be explained due, with that defect. That is the third group. And the fourth group is postoperative PH, where we initially come across it. Either it is flow-related PH, which will usually subside initial few days after surgery, but some of the time it does not regress because of many of the factors. These are the group, I think, classified where I was telling that some of the patient will give trouble. I need to identify once come to the theater or comes to the ICU. Less than 4 PVR, I think most of the talk it has been discussed that these are the patient will not give trouble in the ICU, not always, but most of the time. Most PVRI more than 8, usually the concession will be that these are the patients will not be for the total correction. Between 4 to 8 is a gray area where case to case and the team has to decide about the operability depending on the cardiac catheterization reports as well as other factor to after considering. This is a paper where they have mentioned about pulmonary hypertension in congenital heart disease associated with consensus statement of the expert. And this is a flow chart what has been mentioned that high QPQ has failure to thrive, oxygen saturation more than 95% and only left to right. So these are the patients considering the age, size and type of the lesion, they can directly go for the surgery. If it is not there, these other factors are worrisome, then we need to go for the cardiac catheterization where the PVRI less than 6 and PVRI SVR ratio less than 0.3 will be, AVT will be optional. Some of the paper it is mentioned PVRI 4, some of the paper it is mentioned 6. And then if the PVRI more than 8, they have to compulsory go with cardiac catheterization diagnostic cath. And then if the result is favorable, they can go for the surgery, but still one has to be careful because of the risk involved in closing the fully defect. So some of the time fenestration can be left behind. So positive response will be a drop in PVRI either 6, some of the paper mentioned 4, or PVRI SVR ratio less than 0.3. For the single ventricle pathway, this paper has suggested that mean TPG has to be less than 6 and PVRI has to be less than 3. So this is I think a consensus and guidelines. Many of the expert and author are sitting here. I am privileged to quote few of the things out of this paper. So this paper and the guidelines has taken 31 pediatric cardiologists and pulmonologists from 14 different countries. And then what the introductory paragraph they mentioned, there is no clear association has been demonstrated between postoperatively pulmonary hemodynamics, including acute response to vasodilators and outcome, and therefore it is difficult to define a specific level or levels of PVR that allow safe assignment to perform the cardiac surgery or preclude it. But this paper they have mentioned about the late presentation, absence of pulmonary congestions, associated symptoms, post-tricuspid communication, bidirectional sending across the communication, systemic oxygen saturation less than 93%, and presence of complex congenital anomalies. These are the subset one has to be worrisome before taking directly to the theater and has to be either go for a cardiac catheterization or discuss depending on the clinical features. I will go through very quickly about this paragraph that for the cardiac catheterization, the goal has to be discussed. Diuretic and systemic vasodilators has to be discontinued. Hemoglobin levels should be adequate. Use of judicious sedatives and anesthetics should be there, and proper hemodynamics while you are collecting the catheterized data, because depending on this data, we are going to offer the patient surgery or we can sometime write it off. So what this, how to interpret data in this paper also they have mentioned that the PVR measurement that absolutely contraindicates the surgery in PH-CHD has not been established. Second is the acute pulmonary vasodilator test has not been shown to predict outcome. And the third is general agreement that hemodynamics and the result of acute vasodilator testing should be considered in context of clinical history, physical examination, and non-invasive diagnostic evaluation. So coming to the absolute management, this I have divided into 3 parts. One is to treat the pulmonary vascular resistance, which was there pre-operatively. The second thing is we have to maintain the cardiac output, and the third thing is to maintain the preload adequately. Coming to the reason of persistent post-operative PH, and it may be due to preoperative lung congestions like in obstructed PVR, truncus arteriosus, large AP window, AV septal defect, multiple VSTs, interrupted aortic arch with VSTs, mitral stenosis, or there were supramitral ring, syndromic association, airway abnormalities, and lung congestion. These are the reasons we have a postoperative also the lung congestion, which will affect the VQ mismatch and can affect the PA pressure. The other reason of persistent pulmonary hypertension after surgery will be non-compliance or small LA or underfilled LV, especially especially in TAPVC repair, dilated LALV, especially in multiple VSTs and other defects. CPP-related lung congestions usually will be there, which also causes VQ mismatch. If you are using multiple blood products, especially in neonates and complex surgery, there will also they affect the lungs, and that also can cause VQ mismatch. Or there will be residual gradient, residual defect, or residual valve regurgitation. These other things will affect post-operatively apart from native pulmonary vascular resistance. We usually put PA line in many of the cases where we feel that these are the patient will have a higher PA pressure or the tendency of PA crisis post-operatively. Coming to the management, I feel that initially one has to be there to optimize the respiratory things, to reduce the PVR and afterload. For optimization of ventilation, though it is very basic to say that increase the FiO2 or maintain the optimal FiO2, because it is very potent pulmonary vasodilator, and most of the time we forget these and start very higher agent, or which may not be required usually. The second thing is regarding about the PaCO2 for initially. Reduction in PaCO2 will reduce the PVR, but some of the papers suggest that it not always causes reduction in PVR. But one thing is very clear, that higher PaCO2 definitely increase the pulmonary vascular resistance. So one has to be careful. It should not be reduced too much, but should be maintained between 35 to 40 or maximum 45. Coming to the optimization of lungs recruitment and optimization of PEEP is very important post-operative, because a lot of lung congestion and atelectasis happen after surgery, and this is also one of the reasons that the patient will have a high PVR due to the VQ mismatch. Increasing the PEEP does not always increase RV afterload, because if we are increasing or optimizing the PEEP to maintain the level of FRC where the RV afterload will be minimum, so one has to be maintain it adequately. Coming to the second thing is specific pulmonary pulmonary vasodilator. In those cases, I think for the operation theater and immediate postoperative, we have inhaled nitric oxide available. Few of the studies suggest nitric oxide, NTG and milrinone inhaled, and few of the case report on this. Sildenafil IV oral is available to start with. Bosentan and ambrisentan also is available only in oral forms, or some of the places inhaled ileoprost is available for immediate postoperatively. These are the, I think the slide most of the people knows here, so I am going to skip over this. So coming to the specific inhaled nitric oxide, it is highly lipid soluble and diffuse rapidly through the alveolar membrane and reach adjacent precapillary and pulmonary arteries and causes pulmonary vasodilatation. Excess nitric oxide rapidly inactivated before it transferred to the systemic circulation, and it is highly selective pulmonary vasodilator and no downstream effects. And that is why it is very ideal to use, because it is rapid effect, and usually it goes to the area where the lung is been ventilated. So there will be not increase in shunt fraction and improve in VQ mismatch. So these are the things available, but not, nitric oxide, we are having an inhaled nitric oxide delivery system is INOS system, which is usually can be used only on constant flow ventilators, so it is difficult to use inside the theater. The Knox box we can use any place, which is very costly. That is why it is not available in our hospital. But regarding few of the things about nitric oxide is the exact dose is not been determined precisely. Dilutional effect, there will be always dilutional effect on FiO2 when we start nitric oxide. One has to be careful about impurities about nitric oxide and monitor the methemoglobin level. 4% is cut off. Rebound pH usually we see, so sometime we have to start IV sildenafil before weaning nitric oxide, and it has to be slow weaning. There will be cases where nitric oxide non-responder will be there, and because it is cost of nitric oxide delivery system and nitric oxide, many of the institute, not in even India, some of the abroad also, they are not preferred choice to start. But if it available, this is ideal. Even for me also, I prefer to start nitric oxide. In spite of doing all these things, the PA pressure is not maintaining well, then one has to be look careful about residual lesion, do epicardial echo TE to find out residual lesions or defect, and then correct it immediately inside the theater. Coming to the PA crisis, usually one should try to avoid getting into this kind of a scenario, because if it is happening, there are associated with a very high mortality. If it is happening, I think hyperventilation, increase FiO2 and inhale nitric oxide, and if it is very much severe, then one should report it that ECMO support is helpful. Coming to the optimization of ventricular function, because of after surgery, few of the cases were non-compliant LA and will receive full cardiac output. Underfilled LV exposed to the full preload with high afterload. Dilated LV exposed to the high afterload after surgery, and some of the time RV have directly work against high PVR, and global function of ventricular function also hampered after cross clamp. These are the reason ventricular dysfunction happens after surgery, which will usually affect the pulmonary vascular resistance. So preferred choice of, we usually start low dose of adrenaline if it require. Milrinone is preferred first line of choice, and calcium infusion most of the cases. Vasopressin, noradrenaline, levosimendan has been reported, depends on the institutional policies. Ventilation optimization usually help even for the ventricular dysfunction also, and most of the neonatal cardiac surgery, as well as many of the cases, I think we do MUF, which will help overall reduce inflammatory markers. It improves the global ventricular functions. It improves the lung compliance, as well as improve the pulmonary functions, as well as it reduces the total body water and increase the hemoglobin. These are the beneficiary effect of MUF, and usually it will help in reducing the PA pressure immediately after coming off the surgery. Specific strategy to reduce the PA pressure or manage PA pressure, like in TAPVC, it has been reported that vertical vein left open for initial few days to reduce the PA pressure. It will help in reduce the PA crisis and help in reducing the low cardiac output immediately after surgery. It acts as a temporary venous reservoir and temporary pop-off. What our unit policy is that we ligate vertical vein in all unobstructed TAPVCs, but in obstructed TAPVC we'll leave behind after coming off, and before sternal closure or later on we can deal with it. Keeping the sternum open also is one of the helpful strategies to maintain the lung compliance, as well as due to the myocardial edema, it will give some time to improve the ventricles. So this is one of the strategies which will definitely help in managing the PA pressure as well as ventricular dysfunction immediately post-operatively. If these are the things is not working, then ECMO support definitely help. But before ECMO, I think we still have a choice of starting high frequency oxygenation, because many of the children PO2 and PCO2, because of lung compliance was not good, it has been remain on higher side, and that is why the PVR remains on higher side. It is very safe if we are using it properly, and it definitely help in many of the children which we have used here, where the lung compliance is very poor and there is a significant VQ mismatch present. So in spite of all these efforts, one need to think about perioperative infection in our country, and then definitely has to be close monitoring and give some time. These are the patients definitely improve after a few days. Thank you.
Thank you, Kamlesh, for this extensive thing, getting it together.